Roughly 1 in 4 Oregonians live in a rural area where geography and provider shortages can make accessing care a challenge. Lawmakers who understand both the clinical and policy aspects of healthcare are uniquely positioned to bridge the gap between lived experience serving patients and the decisions made within the legislature. Representative Cyrus Javadi brings that perspective to his role as a lawmaker and a member of the Oregon House Committee on Healthcare. The question for today is, how does Representative Javadi's firsthand experience as a dental provider shape his approach to advancing healthcare access for all? Thank you for joining me today, and welcome to What the Heck? Health Education Conversations, a podcast from the Oregon Primary Care Association. Here we explore the health policies, partnerships, and care teams shaping community health across Oregon. From healthcare delivery to workforce challenges, this podcast brings you conversations that inform, inspire, and spark the transformation of care to sustain a reliable, high-quality network for those in the most need. Each episode features conversations with primary care leaders and partners working to strengthen Oregon's healthcare safety net, as well as expand access to care for all Oregonians across our state. I'm your host, Dani Gehrke, and I'm curious, what the heck is going on in community health? Before we dive in, I'd like to thank the physician office dispensing experts at RX Fusion for making these conversations possible. If you're looking to improve patient outcomes, speed time to therapy, and improve revenue, RX Fusion allows you to dispense medications directly in your practice, boosting satisfaction for both staff and patients while saving money compared to contract pharmacy. I'm sitting down with Representative Cyrus Javadi, who represents House District 32, which covers all of Clatsop and Tillamook counties and part of Columbia County. I would love for you to tell me more about yourself, especially why you pursued dentistry.
Oh, happy to. Boy, where do I start? I grew up kind of all over the country, but primarily Utah. It was kind of where I went to high school and had dreams of becoming an architect. Wanted to build homes, design homes, and went to college. And once I got to college, everything changed. I wasn't so hot to trot for architecture anymore, and I, at that time was considering either medicine or something else. And so went back to school to pursue dentistry. So now I count teeth instead of auditing people's financial accounts and taxes. It wasn't that I grew up dreaming about teeth either. I was terrified of the dentist as a kid. Thought that it had been one of the worst places to have to go twice a year. But my dad was pretty good about taking me. But once I became an adult and went out into the world and started interacting with people in different professions, I really took an interest in medicine. But within medicine, dentistry was one thing that would allow me to see the same patients every 6 months. You got to know them and you really helped people, whether it was a new smile or getting them out of pain. And so that was one of the things that attracted me to the profession, wanting to be of help, wanting to help people solve their problems and do something that was tangible and beneficial to people that they couldn't do for themselves. I also grew up kind of interested just in systems, like how do things work? How do incentives shape people's behavior? And how do small problems, small failures kind of ripple outward? Dentistry, in that sense, turned out to be, if not a perfect mix, a really nice mix of that. And like I said, something very human. It's medicine, but it's also very practical. You can take someone who's in pain or scared or embarrassed or avoiding care altogether. In that visit, that moment, you can really do something for people that makes a difference, that makes them feel better or solves a problem. I recently had a woman who came in and was missing one of her front teeth and just was too embarrassed to even go back to work. Or I think in her situation, she was actually just looking for work. And so too embarrassed to even get a job. So it's kind of fun and kind of rewarding in that way.
My father, one of his front teeth had to be removed, and for a long time, he would never smile until he was able to get his implant. And after that, he's like, oh, look at my beautiful smile. So, to your point, it's a confidence boost as
Yeah.
well, in addition to your overall health.
Absolutely. I had gapped out teeth when I was a kid, so my dentist did miracles with my mouth. We understand how important it is. It's a way that we can make a difference in people's lives, being able to provide that. So definitely what drew me to dentistry.
What got you involved with Tillamook County, especially as you are the acting dental director?
Yeah, I moved to Tillamook County in 2012 and within a short period of time became involved with the health department who needed support. They didn't have a dental clinic themselves, so they were contracting with local dentists to help provide care. So we started to provide some contracted care with the health department to help them out. And then over time, as we got better at enrolling people in Oregon Health Plan and the need became greater, especially in rural counties like Tillamook, they needed to have their own clinic, but they also needed some supervision of the dentist contracts they had. They didn't have the expertise at the county to make sure that the quality of care and consistency of care was adequate. So they wanted a dental director to give them some advice and to help them navigate running a clinic to make sure that things were going the way that they should. They were up to a certain standard. And so I started in the dental director role probably around 2016 or 17.
What is the difference between a private practice and working in dental services for a fairly qualified health center?
Yeah. The biggest difference is the mission. A private practice, like I work in, is built around patient choice and sustainability, whereas an FQHC, a federally qualified health center, is built around access, specifically access for people who would otherwise fall through the cracks. So at the FQHC, you're seeing a much higher percentage of Medicaid and uninsured patients. Often with that population, they have years of deferred care, right? They haven't been in a long time because they couldn't afford it. They didn't know where they could go if they had Medicaid. And sometimes, even if they knew where they could go, it was such a long wait. According to HRSA, over 90% of patients who go to the FQHCs are below 200% of the federal poverty level, and about 60% are on Medicaid. That really changes everything from scheduling treatment planning to staffing. You're not just doing dentistry, you're navigating things like transportation barriers, language access, housing stability, instability. The work is often harder and it's also less financially forgiving, and I think that's a huge component. Not only financially unforgiving for patients, financially unforgiving for the system providing it, for the FQHC, which is ironic because that's where the need is the most acute, and it's financially unforgiving for patients because it's expensive. Even with Medicaid or uninsured, that plan, Medicaid, which Oregon Health Plan, only really covers a few things. Now, it's pretty good in the few things that it covers: fillings, root canals, cleanings, x-rays, emergency care. But that only takes care of 50 to 60% of what a patient may need at any moment. It doesn't cover a lot of treatment like crowns for molars. It doesn't cover root canals on molars. It doesn't cover replacing missing teeth. It does cover dentures, but only some kind of dentures. And so you have a patient population that will happily get what they can covered and are grateful for it. But when they need to replace a front tooth, there are rules on whether they can qualify. For example, you can be missing 5 teeth, but until you're missing the sixth tooth, their insurance isn't going to help out.
Oh,
And so when you're in that situation, that means that's going to come out of your own pocket. And for patients, that can be very expensive for a group, like I said, that's making less than 200% of the federal poverty level can eat up their budget. And for the provider, the reimbursement rates are so low. And so you are making trade offs constantly. And unless you have another source of revenue coming in to make up the difference for what Medicaid doesn't cover, then you don't have the extra funds to invest in broken equipment when it fails. Oftentimes, staffing's limited because you don't have the resources to pay for a robust staff complement. So your wages you offer are often less than competitive as well. And all of that combines to limit access, make it very difficult for providers to provide ready care for patients, and it makes it hard for patients to get all the care they need. It's a very difficult environment to work in, but it's also, like I said, where the need is the greatest, the most acute.
I was curious to know what holes you saw in the healthcare delivery system here in Oregon, and you went into the Oregon Health Dental Plan. I'm wondering, are there any other holes that you see and how health centers like Tillamook County can fill those gaps?
Sure. You asked a really good question. What are the other holes? The biggest hole is pretending that insurance, whether it's Medicaid or otherwise, actually equals access. Oregon covers more people than ever before, right? And like I said earlier, reimbursement rates, especially in dental care, often don't really even cover the cost of care. Workforce shortages are severe, and nationally, over 60% of health professional shortage areas, the HIPSA, are rural. And Oregon is no exception. So, community health centers, they fill that gap by cross subsidizing care, leveraging federal grants, and coordinating services all under one roof, like medical and dental and behavioral health. But that's really like duct tape, right? And goodwill. It works, but really, it's pretty fragile because it only takes what we're seeing right now, where the federal government's cutting Medicaid funding, one little leg of the stool to get shortened even more before we start to see the cracks widen and the whole thing come apart. So I think when you're really talking about the holes, there are many holes, but they all kind of fall under that one umbrella, which honestly is reimbursement and geographic location. Geographically, in a place like Tillamook County or Clatsop County or out in Eastern Oregon, again, Morrow County and others, you don't have the resources out in the community to provide the training that you need to even staff a dental office. So if you can get a dentist to come to your community for the purpose of providing basically public health care, then you also need staff, but that means you have to offer wages competitive with private companies or wages that you would find in the Willamette Valley, plus housing, which is in short supply. So, really, the biggest barriers right now are sustainable and sufficient funding combined with staffing, making sure we have people in the pipeline coming through. And right now, we cover more people with Oregon Health Plan, and not just Oregon Health Plan, but other insurance than ever before, which means the demand is still there and will always be there, yet we're not able to meet that demand with supply. And so that's what really severely limits access is the combination of all those different factors.
You've mentioned rural communities, including frontier communities as well, when you were talking about Eastern Oregon. I would love for you to share why is it so crucial to advocate for underserved communities?
Let's see. Why is advocating so crucial? Because systems don't just work on their own, they don't correct themselves without help. Underserved communities aren't underserved by accident. They're underserved because of policy choices and funding formulas and a tendency to design healthcare around ideal patients who've got time and who've got money and who've got flexibility. And advocacy matters because someone has to say, well, this doesn't actually work in the real world. We have a compassion problem and we have an efficiency problem, and everybody suffers. Unless we're advocating for people, regardless of their ability to pay or the geographic location they live in, or advocating for the providers who are willing to do the work, the whole community suffers. If we believe that healthcare is about human dignity, and I do, then advocating for underserved communities isn't charity, it's basic maintenance of a system that's supposed to serve everyone. I'll continue to advocate both for patients and for the providers that are willing to do that. And so I think the impacts will be felt throughout the community, especially small communities where everybody depends on each other and the limited resources we have.
As we move to the end of our conversation, here at the Oregon Primary Care Association, we emphasize the importance of federally qualified health centers building strong relationships with lawmakers. Often, health centers will invite representatives to visit their sites to gain an inside look at how health centers deliver care. Representative Javadi's direct connection to Tillamook County Community Health Centers takes that relationship a step further, as he is part of the community health center model. His experience as a health center provider allows him to understand the realities of delivering affordable, high quality care in rural areas, as well as the workforce challenges of recruiting and retaining providers in communities with high demand and limited resources. That perspective is valuable as it informs how he approaches health policy. Representative Javadi's last comment that healthcare is about human dignity is a powerful reminder that advancing healthcare access is about understanding the people, policy decisions impact, and the systems that serve them. In our next episode, we'll shift to a commentary session with Marty Carty and Aaron Woods from the Oregon Primary Care Association policy team to hear their thoughts on the conversations with Representatives Ed Deal and Cyrus Javadi. They'll also share their work experience within the legislature, how that informs their work at OTCA, and why advocacy is more important than ever. I love having conversations with these two and really appreciate their insight and thoughts, and I think you will too. If you don't want to miss the next episode, make sure to subscribe to this podcast to receive notifications of when new episodes are released. Today's conversation was produced and edited by Dani Gehrke and fact-checked by Priya Thoren, who also helped with research. I'm Dani Gehrke with the Oregon Primary Care Association, and thank you for listening.